I'm Dr. Pete Littler from Newcastle. I'm an interventional radiologist, and I'm pleased to be joined today by Professor Afshin Gangi from Strasbourg and London. Thanks for joining us.
Thank you, Pete. I'm happy to be here.
I was just wondering if you could tell me a little bit about interventional oncology.
For the patient view, I think interventional oncology, we are very lucky. We are one of the specialty moving fast in the field and bringing something new for the patients. We are part of the team of oncologists, radiotherapy surgeons. We are sitting with them in the multidisciplinary team, and we discuss every case differently, and personalized medicine means for every patient, we can discuss what is the best for them, and we bring them our minimally invasive technique. That could be ablation, that could be pain management, that could be focal treatment of a single meds, multiple meds, which are moving. What is new for us and for the patient is when they are treated well oncologically, but some tumors are resisting, but they respond to the treatment. Usually we come and we take away the one which are resisting to the conventional treatment. So we keep the line of treatment and we save the other lines to stay at this line, and we treat the patient. We can be very fast. Recovery, usually they are 1 night or 2 night maximum in the hospital. If you have no complication for the patients, going back to the family and their house is very important.
So it's a very different experience that the patients will have compared to traditional treatments like surgery.
Absolutely. And the acceptance for the patient is very well, because we see them before, we see all these patients before, usually even with the oncologists together. We have a consultation, oncologist, me, eventually even other surgeons, and we tell exactly what we have decided for the patient, and we ask if they accept what you are proposing, and we go through this, and then we treat the patients. We follow them up ourselves, we see them again, and the patients know exactly we are taking care of them. And anytime, any problem, they can come back to us. We are really part of the chain, and we are clinicians operating on the patients.
Fantastic. And so we're offering sort of minimally invasive treatments for them.
Absolutely. That could be thermal, that could be chemical, that could be cryoablation, that could be electrochemotherapy, that could be radiofrequency, microwave. Every case is different. So radioembolization. We have so many different treatments, which is personalized for the patient, and we propose them the best. And again, not because we are many specialties together, we decide really, without fighting together, say, okay, in this case, I'm better. In this case, you are better. Or in this case, we should be all together.
Yeah.
And for the patient is a lot more comprehensive because we explain to them all together what we are doing and why it's better for them.
Yeah.
And the complication rate is less, recovery time is less, and one thing you should not forget, the cost is less.
So we're not competing with the other specialties. We're kind of offering the best thing for the patient. Absolutely. On a case-by-case basis.
Personalized medicine, and again, as you have seen, the problem today is access to the treatment. And all of us, we are so busy. It is not the time that everybody fight to get the patients. We are all very busy, and we want to provide the service. So we work together, and we are enjoying it, working with the team. All specialty, I'm learning from them, they learn from me, and even sometimes surgeons are coming to my room to operate with me. It makes it a lot more comprehensive for the patients that they see us all together for their interest.
Fantastic. And we're offering sort of minimally invasive treatments that can be done under local anesthetic or general anesthetic?
Yeah, for some tumors, for example, you are right. For superficial tumor, if the patient is not too anxious, we can do it on the local and the patient is home in the afternoon. Some benign tumors, like endometriosis, for example, recurrence on the abdominal wall, those patients are coming, they talk to us, we put the music for them, we do local anesthetic, we do the cryo, we all talk together, and we follow them up 2-3 hours in the recovery, and they are home.
Fantastic. So
it's a huge difference.
Yeah, a massive difference. So we're offering these patients minimally invasive treatments for their cancers. They can be either general or local anesthetic, and they're either home the same day or next day, typically.
Absolutely. I think for renal cancer, for example, the change is huge. We are treating a patient we needed before robotic surgery or, blood loss, things like this. We can combine different treatment, and those patients can be usually after 1 night or even in the afternoon if they are in a good environment. If they're living far, no. But if they are living near us, they can be in the afternoon home with a renal cancer treated.
That's really fantastic to be able to offer that to the patients.
We are really lucky. We are living in the right time with a fast evolution and a nice service. We have a really lucky specialty. I think interventional radiology and interventional oncology, we are born in the right time. with huge evolution and very young generation of doctors who are doing it.
Yes.
That's very, very nice to see this enthusiasm of young, very good doctors, high class, in the exam, the best one coming to our specialty. This is really rewarding.
Yeah, it's exciting times, isn't it, to be an interventional oncologist?
Absolutely.
Okay, thank you. Thank you very much, Afshin, for that.